temporoparietal region. The presence of mass effect and midline shift depend on the size of the clot. We can see the epidural hematoma, and this is the skull fracture. We can see the epidural hematoma here. Operative management. The indication for operative management include cause larger than 15 mm in thickness, with volume greater than 25 cc or with associated compressed basal systems, and the midline shift should be evacuated. Epidural hematoma in the posterior fossa or temporal region are especially dangerous and should be managed non-operatively only if they are small, the patient is in a very good neurological condition, and can be followed very closely, both clinically and with frequently CT scan. An acute subdural hematoma is ASDH is characterized by accumulation of blood between the dural mater and the arachnoid layer within 72 hours of injury. In elder patients, they are the most commonly seen after falls, especially in the face of anticoagulation and alcohol abuse. In young patients, it's usually caused by high-speed motor vehicle accidents and assaults. Most often, ASDH are caused by rupture of bridging vein that traverse subdural space. The initial forces, acceleration or deceleration at the moment of injury, usually are of short impact and abrupt angular acceleration, and therefore occur at the periphery of the brain. The ASDH is usually accompanied by ipsilateral hemispheric brain swelling, which contributes to the severity of the clinical picture. Patients with an ASDH are usually comatose, with ipsilateral pupil dilated. Patients with an ASDH are usually comatose, with ipsilateral pupil dilated, hemiparesis on the contralateral side, and often extensive posturing. Diagnosis of an ASDH is established by visualization the crescentic hematoma extending over the frontotemporal parietal region, commonly with mass effect, herniation of the uncus, midline shift, associated brain swelling, effacement of basal system, and dilation of the contralateral temporal horn. The typical subdural hemorrhage is more diffuse than an epidural hematoma and has a concave inner margin that follows the surface of the brain. However, most acute subdural hematoma are hypotense, most subacute lesions are isodense or mixed density, and most chronic hematoma are hypodense as compared with brain tissue. Here we can see the ASDH. A patient with at GCS of 13 or high. Patients with a Glasgow Coma scale of 13 or higher, absence of associated intracranial hemorrhage, contusion, edema, or effacement of the basal system, midline shift less than 10 mm, and hematoma volume less than 25 cc can be initially measured conservatively. In patients with low GCS score and or evidence of herniation or high intracranial high pressure, surgery should be performed as an emergency. Chronic subdural hematoma. By definition, chronic subdural hematoma is a subdural hematoma that is older than 3 weeks. Formation of a CSDH is thought to occur after an initial bleeding in the subdural space, which is usually asymptomatic. The acute bladder may resolve completely. It may enlarge and develop into a subacute SDH, causing symptoms, or it may be liquefied and continue to enlarge, developing into CSDH. In the case of progressive development of a CSDH, expansion of the subdural space occurs, which leads to further bleeding as a result of rupture of small bleeding vein. Most commonly, a CSDH is caused by a minor head or trauma or fall, often not remembered by the patient or relatives. Risk factors are old age, alcohol abuse, seizure, CSF, cerebrospinal fluid shunt, anticoagulation, and patients at risk for fall. The clinical manifestations include headaches, nausea, vomiting, hemiparesis, sensory deficits, language disturbances, gait problems, transient ischemia, attack-like symptoms, and decreased consciousness. CT scan will show a hypo or isodense fluid collection over the frontal parietal regions, often with significant mass effect and midline shift. The hematoma usually achieve a large size before becoming symptomatic because of the slow growth. The operative technique for symptomatic patients involving placed burr holes or twist jaws, a single burr hole and closed external drainage system offer the best results. The CSDH may be accumulated, and a second or third drainage may be necessary. In cases of multiple recurrences, a craniotomy or cranioectomy may be performed with the drainage of the clot and membrane. In cases of multiple recurrences, a craniotomy or a cranioectomy may be performed with drainage of the clot and the membrane. Here we can see the hematoma here, and also can see the midline shift. And from CT scan, we can see the hematoma here. This is for the MR T1 by contrast, and T2. cerebral contusion. Brain contusion is a common consequence of head injury and defined as a scattered hemorrhage involving the cortex and adjacent white matter. Contusion occurs predominantly in the basal frontal and temporal lobes. Also, they can also occur in other lobes of the brain and the cerebellum. The anterior and the middle fossa have bony prominence that predispose this lobe to injury. At the moment of trauma, the inertial forces move the brain against this bony indentation and rupture of small cortical or subcortical vessel. Contusion can enlarge after a significant period of time has elapsed and is very important to repeat imaging studies a few hours after initial CT scan. Presence is variable, in part depends on the nature of the trauma and associated injuries. Some patients sustain small contusion of a minor fall. Presentation is variable. Presentation is variable and in part depends on the nature of the trauma and associated injury. Some patients sustained small contusion after minor fall or assault and have a few available neurological causes. Presentation is variable and in part depends on the nature of the trauma and associated. Presentation is variable and in part depends on the nature of the trauma and associated injuries. Some patients sustain small contusion after minor fall or assault and have a few available neurological outcome. Others have larger contusion at the frontal or temporal lobe, which associated mass effect and midline shift. Interestingly, the mass effect and swelling can become more pronounced during the first 2 weeks because of the development of swelling along the Interestingly, the mass effect and swelling can become more pronounced during the first 2 weeks because of the development of swelling along the contused brain. Cerebral contusion are seen as non-homogeneous of high density, often interspersed with area of low density, we call salt and pepper appearance. The CT appearance results from multiple small areas of hemorrhage within the brain substances associated with air of edema. The margin is usually poor defined. Here we can see the contusion, and this here we can see the contusion and it's enlarged 2 days later. The neurological states of the patient, location of the contusion, presence or absence of basal system, and ventricle on imaging studies, and intracranial pressure will dictate treatment of patients with cerebral contusion. Patients that are awake and follow commands with no significant neurological deficits. The neurological states of the patient, location of the contusion, presence or absence of basal system and ventricles on image studies and intracranial pressures will dictate treatment of patients with cerebral contusion. Abounded or comatose patients with significant contusion and mass effect or midline shift may benefit from a craniotomy or removal of the contused brain tissue. For patients that are weak and follow commands with no significant, patients that are weak and follow commands with no significant, patients that are weak and following commands with no significant neurological deficits. For this patient, for these patients, non-operative management is considered. Intraparenchymal hematoma is defined as a confluent homogeneous area of hemorrhage that occurs inside the brain parenchyma. CRC, most commonly in the frontal and the temporal region, can be multiple in 20% of cases, are usually round-shaped, and occur in the white and the gray matter. Other locations are the corpus callosum, periventricular region, and the basal ganglia. In contrast to contusion, traumatic intraparenchymal hematoma is not thought to be the result of the brain in contrast to contusion. Traumatic intraparenchymal hematoma is not thought to be the result of brain parenchyma impacting against the skull base. The mechanism is usually acceleration and deceleration with sharing of perforation vessels for deep located hemorrhage and cortical and subcortical vessels for the superficial located ones. Clinically, patients are often encountered with depressed level of consciousness, reflecting the high energy and severity of the injury. CT scan of the head show one or more localized and non-contiguous CT scan of the head show one or more localized and non-contiguous hematoma, quite often deep in location. After several hours, lesions that were not present initially or after several hours, lesions that were not present initially or were just punctured, or after several hours, lesions that were not present initially or were just punctured hemorrhages can also enlarge and can be depicted on subsequent follow-up CT scan, the so-called delayed intracerebral hematoma. Edema can be seen along the periphery of the hematoma after a few days, which aggravate the mass effect. Traumatic intracerebral hematoma are usually local. Traumatic intracerebral hematoma are usually located in the frontal and anterior temporal lobe, although they can occur in vertical any area. They are high-density lesions and are usually surrounded by a zone of low density caused by edema. Patients who have evidence of a decreased level of consciousness and evidence of mass effect or shift from a superficial located clot. Patients who have an evidence of a decreased patients who have evidence of a decreasing level of consciousness and evidence of mass effect or shift from a superficial located clot may benefit from a craniotomy and evacuation. Prognosis of patients with traumatic brain injuries and intracerebral hematoma is related to the initial neurological states, location of the hemorrhage, presence of diffuse axonal injury, and intracranial hypertension. From the CT scan, we can see the hematoma here, and the patient undergo craniotomy. The first CT shows us hematoma here, and the patients were performed cranioectomy, and this is the follow-up CT scan. And 24 days later, this picture is 24 days later. And we also can see the hematoma 6 days after head trauma. No surgery is indicated for this patient. No surgical indication for the patients because of the good clinical manifestation. And 23 days later, we can see hematoma here. This is the 6 days after trauma. And 11 days after trauma, we can see the hematoma and the edema along the hematoma. And 24, this picture shows us, the CT scan shows us hematoma here and the edema around the hematoma. And 11 days later, 23 days later, and this is the first CT scan. And 2 days later, we can see the contusion complicated with hematoma. Then 4 days later, the hematoma enlarged. And this is the 6 days after trauma. This is the first CT scan of the patient. The patient undergo cranioectomy and the evacuation of the hematoma. 12 days CT scan can see the skull bump defect. 30 days later and 3 months later, the patient underwent cranioplasty surgery. 最后一张了。
45分钟
啊
45分钟
啊，差不多。最后一张了，还有2、3分钟。The outcome of non-penetrating injuries are improved. The outcome of non-penetrating injuries. The outcome of non-penetrating injury. The last we'll talk about penetrating injuries. The outcome for non-penetrating injury has improved, but the high mortality rate for patients rendered comatose after missile injuries appear to have not changed. Non-comatosis patients almost always survive, also with deficits depending on the path of the bullet. The risk of death in the comatose patient in most studies is about 90%. However, despite this high mortality rate, many centers use the same medical management as for comatose patients with non-penetrating injury. The current standard in most centers is debridement The current standard in most centers is debridement of the first few centimeters of the tract, followed by a watertight dural suture. The current standard in most centers is the current standard in most centers is debridement of the first few centimeters of the tract, followed by a watertight dural closure. We can see the varieties of missile wounds to the head. And this is the intracranial bleeding from gunshot wounds to the head. This is the bullets. And we can see the subarachnoid hemorrhage, and we can see the subdural hematoma, and we also can see the hematoma here, and the intraventricular hematoma. This is my reference. Thank you.